Our next speaker is Dr. Jordan Jacobs. He's a general and trauma surgeon at St. Joe's here in Phoenix. Dr. Jacobs did his medical school at Columbia and surgical training at St. Joe's, and then his fellowship at Rideau Trauma Center in Miami. He's going to talk today about ECMO, the trauma patient.
Make sure I know how to move this. Thanks for the introduction. My name's Jordan. I am a trauma surgeon here at St. Joe's, and I'm primarily a trauma surgeon. I dabble in a few other things, including ECMO, and I'm going to share kind of my perspective on it. I don't have any disclosures except for I definitely had compassion fatigue last night at about 2 a.m. And Dr. Miller, thank you for a truly insightful talk and a reminder for why we do what we do at the time we do it when we're exhausted, and ways to keep energized to do what's important, so thank you. Again, my perspective is from a trauma surgeon. As I said, I dabble in some other things, and some of that is ECMO, and I've had an interest in this for some time, so I've studied it a bit. We're kind of in the early process of trying to do some ECMO for trauma at my center, and so I'll kind of share with you my thoughts and some of the study that I've done in it. So this is my favorite quote when I think about ECMO. All who drink of this remedy recover in a short time, except for those in whom it does not help, who all die. And this was a quote from Galen from centuries ago, and commonly used as a logical fallacy, but I think of it in some things like ECMO, which is kind of our last resort. If this doesn't work, maybe nothing will. And suspended animation may fall in that same category as well. I'm going to break this up into two main parts, a quick and hopefully rapid overview on ECMO and some of its different components and strategies, and then a quick assessment of some of the work that's been done in trauma, which is quite limited, and then my own project that will be coming out. Most of this background that we have available to us is really from this organization, the Extracorporeal Life Support Organization. This is the organization nationally and internationally when it comes to ECMO. They keep a really nice database, which helps us to get some information. So as you look at the trends over the last couple of decades, you can see ECMO in general has really increased dramatically in its use. A couple decades ago, you can kind of see those numbers are difficult to read, but cases were about 1,600 a year in this database, and those are up to 6,000, over 6,000 a year. Ignore 2015 because that's an incomplete year of data. Historically, ECMO was really used traditionally for neonatal cases, and you can see that back in the early 1990s was when that really peaked. And it still is used very commonly, but it's kind of plateaued over the last decade and a half or so. Pediatric cases, so older kids, there's been a pretty dramatic increase that you can see since 2009, and that's really continued over, this chart goes to 2012, but it's really continued over the following years up to 2015 data as well. And it was really at this point that the H1N1 really drove changes in how ECMO was used both in older kids but also in adult cases. You can see even a more dramatic change in utilization of ECMO for adults that really started to occur in 2009 when H1N1 hit. And the other thing that happened at that time is the Caesar trial came out, which gave some data behind and kind of some meat for utilization of this therapy in adults. Quick review of kind of the results of this. Like I said, the Caesar study came out in 2009, and they really compared a highly protocoled single center utilization in ECMO with kind of standard of care at multiple centers that was not protocoled at all for patients with severe ARDS. And you can see here that I lost my screen here. Oh, I can see down there. You can see. Oh, yeah, I can see it down here, but I lost it here for some reason. But what you can see up there is that again the protocoled utilization of this therapy at this single center really showed some advantages in terms of survival at 6 months and those that were, did not have any disability at 6 months as well. There's really two and a third primary indication for ECMO, which we'll kind of go through quickly. End-stage respiratory failure, cardiac failure, and as well as eCPR or ECMO CPR. That's emergent ECMO done for cardiac arrest. You can see there's trends in survival, and the survival, there's very significant trends in that respiratory failure does better than cardiac failure, does better than eCPR, and you can see that for the adult therapy, and it's the same for other age groups as well. Even within respiratory therapy, there's different trends in some of their survival for the different causes of the respiratory therapy. However, for the most part, when you look at these big databases, the folks that are treated with ECMO for respiratory failure, their survival is somewhere between 50 and 60%. You can look at really a talk on when ECMO is indicated and specifically when is the ideal time to cannulate somebody. That's a whole talk kind of within itself. You can find a whole handful of guidelines, but basically for when it's done for respiratory failure, it's refractory respiratory failure despite best therapy. There are some guidelines that say, if you have very sick, high P/F or low P/F ratios or high Murray scores are some clear indications or some considered indications. You can see some of those numbers there that have been suggested. For cardiac failure, similarly indicated with refractory cardiac failure despite best therapy as well. And you can see some of the common scenarios in which that's the case in that list there, again published in some of the ELSO guidelines. When you think about contraindications to these therapies, this also is a widely debated area with little agreement. And some people say there's no true contraindications for respiratory therapy for this. And for cardiac failure, it's only when you have an unrecoverable heart that for whatever reason they're not a transplant or a VAD candidate. You can see a couple things on the bottom. One is that most people would agree if there's some type of uncorrectable disease process and you can't fix that disease process by bridging them to a transplant, that's a pretty strong contraindication. And then prolonged CPR and hypoperfusion is another. However, how you define prolonged CPR is something else that can be debated. Here's a handful of things that are really relative contraindications. And after about 14 days on high vent settings, your survival curve really drops on ECMO. And so a lot of folks will say prolonged high vent settings without putting them on ECMO earlier is one of those. Advanced age, we'll talk about that a little bit more later. Obesity, and then the big one, especially in the trauma setting, is those that are at risk of anticoagulation, and we'll discuss that a little bit more. So here's a case of a patient I took care of that unfortunately expired from her severe ARDS with achondroplasia and severe obesity. She would have been a great ECMO candidate, but just unable to gain any access because of really just anatomy for her. Another example of a morbidly obese patient that really needed ECMO because she had a tracheal stenosis and was about to lose her airway in correction of that tracheal stenosis. But imagine trying to put a 29 or 31 French catheter into that IJ that you see there. Very difficult. So another potential contraindication is bad atherosclerotic disease. This was a patient that went on VA ECMO. However, we had really poor flows because of her pretty bad vessel disease. Let's talk a little bit about VA versus VA ECMO. You can see some of the kind of compare and contrast here. The main take-home point is that VA ECMO is when you got a bad heart and maybe bad lungs. VV ECMO is for bad lungs and a good heart, or at least an adequate heart. You can see a couple of the other advantages of VV ECMO listed there, and that you have some nice things that you can do with peripheral access, and you don't have any access limb ischemia issues with VV ECMO as compared to VA. There's been a real trend that you can see there because of the advantages that I just mentioned, and also because of the increased utilization with VV ECMO for adult respiratory failure, that VV ECMO is really increasing and VA ECMO is decreasing over the last decade or so. There's a handful of different real formulations of this, and I'll run through these kind of quickly here. So I love these illustrations. I think all of my critically ill patients look just like this guy. Done from a recent review, but nice picture. So here's VV ECMO, and you can see here you're draining venous fluid from the inferior vena cava. It goes through your circuit and is reperfused back oxygenated through the superior vena cava, and ideally will be trajected across the tricuspid valve and will go over to the left side of the heart. Here's a single access VV ECMO, and this is one of the real advantages of it. A little bit of a blown up picture of one of these cannulas. There's a couple of different manufacturers that make these. Where with a single cannula you can drain from both the IVC and the SVC, and if thing is positioned properly, the oxygenated blood will be trajected directly back towards the tricuspid valve. And here's an example of a patient that we put on, which we bridged to a lung transplant. Hopefully that cannula shows up, but it's nice to be able to put in a single IJ cannula in order to do this. They're very large, 31 French usually, and a potential benefit is you can take this studly, critically ill patient and you can wake them up, you can mobilize them, you can sit them out of bed. There's even reports of ambulating with these guys. I mean, this guy looks like he can do like a P90X workout or something. So maybe Peter Ree would look like this if he had an ECMO cannula in. But there are some tremendous advantages to single site VV ECMO. Moving on to veno-arterial ECMO, here's an example of femoral veno-arterial ECMO. You drain from the IVC through the femoral vein, and you reperfuse back through one of the femoral arteries. And you get some cardiac support with this. With VA ECMO, you can also consider peripheral versus central access or cannulation. And here's a little chart in a moment. One example really quick. This was a trauma patient that I took care of in fellowship that had a massive PE afterwards. We did a PA embolectomy on him, and he ended up with severe right heart failure and was on central VA ECMO. So a couple of the advantages. I mean, the main thing is that with central access, it's obviously much more morbid in terms of access. It requires an open chest as compared to peripheral. The main advantage to it is you don't have an issue with mixing, which I'll describe here in a moment. And then also you don't have any potential with limb ischemia when you go centrally. If you look at this, if you look at the aortic arch, you have blue kind of mixing with red, which is going retrograde, and it turns purple. It's where it turns purple, where the oxygenated and deoxygenated or poorly oxygenated blood is mixed. If it happens where it looks like in this chart, it's not that bad because you're getting oxygenated blood to your brain, and we like that. If it happens further down in the thoracic aorta somewhere, that can kind of become a problem, and there are some different things to do with your setup in order to correct it, but that's one of the advantages of central access. Here's one other example where you can do a cut down without having to open the chest and put a graft on the subclavian artery and essentially get central VA ECMO without having the morbidity of an open chest. Real briefly, there's been some really dramatic improvements in the technology, three specifically that I'm just going to refer to here, but it becomes important in what we discussed later. The ECMO pump is really incredibly changed, going from the roller pump to centrifugal pumps. The actual oxygenator themselves has had some pretty dramatic changes that have happened over the last decade or so. And then really, and I think this is of particular importance to trauma, is that the miniaturization of the circuit and heparin-coated circuits have really allowed for the potential of going on ECMO with either decreased or sometimes no heparinization. More on that. One last thought in that ECMO does nothing to correct the disease process that it's being treated. So that's critical to understand. It's only a bridge. And what you're bridging to is the critical question that you have to answer before you put anybody on. Are you going to bridge to recovery? Are you going to bridge to transplant? Can you bridge to a VAD if it's cardiac failure? Can you bridge to decision? Maybe you just want to buy more time and you're going to say, we're going to go on ECMO for now because we don't know what to do, but we're going to bridge to a decision. So you don't want to end up on a bridge to nowhere, because that becomes a real challenge with dealing with the patient, family, and making decisions. Let's move on quickly to ECMO and trauma. And these are just a few of my thoughts as I've thought a bunch about this particular therapy for trauma. So when you think about some of the respiratory criteria, and I'll really focus mostly on respiratory failure and trauma, it's not uncommon that we see trauma patients with any or all of these potential criteria of really severe ARDS and respiratory failure. When you think about some of the systemic criteria, so you want to have somebody, again, that has a reversible disease process. And with trauma, that's often the case, okay? A lot of our trauma patients, not all, but many of our trauma patients are young and otherwise healthy, so they don't have a lot of other obstacles medically. You don't want folks that are extreme of age, and I've talked a little bit about this before, and some people take offense at age 60, so maybe you want to think about 70, or I don't know, 80 is the new 60, so please don't take offense. But a lot of our trauma patients are younger, and so that's frequently is not an obstacle. But the biggest issue, as we all know, is risk of anticoagulation. And so whether or not this is a true obstacle, we'll talk about it a little bit. So because traditionally you're going to heparinize somebody in order to cannulate them, and then you're going to, whether you're following ACTs or PTs, and there's different protocols, you're going to keep them anticoagulated in order to prevent your oxygenator from clotting. The data on this in trauma is really very sparse, and the large majority of anything available is simply people's experiences, mostly with a single or sometimes a small set of patients here. Here's just one example out of Germany of folks who treated very sick patients, a very low P to F ratio, as you can see there, for refractory respiratory failure, put them on ECMO despite the fact that they were polytrauma, and all three of these patients survived. So this really is the majority of what you're going to find in the data, is that we've done it and it's worked in this scenario. There's really three of a larger case series that have really shown some benefit, and I'll kind of move through these kind of quickly. So the first was by Andy Michaels out of Michigan, and this was way back in 1999, where he published really the first kind of larger case series of 30 patients. Again, very sick patients, a mix of VA and VV ECMO, and one of the earliest examples of, hey, we can do this at a center, and these folks had a 50% survival rate, which was at least comparable to other folks. This is out of the UK, a little bit more recent, 2006, 27 patients, again, very, very sick, a near 70% survival rate, with a caveat that they only followed patients to discharge from their ECMO ICU, okay? And then most recently, small numbers, but just pay attention to 19 patients, 2015, out of Taiwan, with a survival rate in the 60% range. I think that's 68% that you see there. Again, very sick patients. And so it's very difficult to study this because there's no single center, even the high volume centers, that get really high volume. You can see here for my search, these are all the numbers of studies that have really focused specifically on ECMO and trauma. And so myself and some of my thoracic friends from our center got a hold of the ELSO database, and again, large database, over 60,000 patients, over 250 centers internationally. We queried the database from 98 to 2014, and really we were limited to ICD-9 diagnoses, and in searching for those with blunt pulmonary contusion that were on ECMO, that resulted basically 85 patients with complete data, and we really want to know what the survival rate, really simple, and did they have hemorrhagic complications. So young patients, very sick, as you can see, P to F ratio of average of 59. You can see their average hours on ECMO there. Again, hypoxic. Some of them had issues with hypercarbia. You can just see summary of the patient population here. When you look at the temporal trends of when they were placed on ECMO as the kind of years went on, and there was no difference in survival if you looked at kind of 4-year increments here. It wasn't like they got better over time. No significant difference in survival rate over the years. What type of therapeutic support they're on? Many of them were on vasoactive drugs. A lot of them had advanced respiratory support, either nitric oxide or oscillator prior to going on ECMO. And about 3/4 of them were placed on VV as compared to VA ECMO. Those that had risky associated injuries for hemorrhage, about a third of them had ICD-9 codes of injuries that would make them at risk for hemorrhage. You can see a list of them there. Many of them with head injuries. You can see hemothorax, solid organ injuries as well. Many of them had procedures either just before or even during ECMO. Again, about a third of them were coded as having procedures either just before or during ECMO. These are some of the procedures, some minor procedures, but some major as well. And this particular patient population had a 74% survival rate. And that, as you know, compares very favorably with the rest of the folks that were treated for respiratory failure from this database, which is in the mid-50 range. When you think about the hemorrhagic complications, almost 30% of them had a hemorrhagic complication. And you can see the different types there, either a surgical site bleed, a cannula site bleed, or DIC is coded as a hemorrhagic complication in this particular database. The hemorrhagic, whether they had underwent a procedure or had an injury at risk for hemorrhage, none of those correlated with whether or not they had a hemorrhagic complication. And when you tried to, this is our univariate analysis, but it was a multivariate analysis that demonstrated that veno-venous ECMO as compared to VA ECMO and decreased hours on ECMO predicted survival. None of our other variables panned out significantly. Just to kind of wrap up with a couple other thoughts. So again, it seems like trauma patients could potentially present ideal complication if we can get over this potential bleed risk. So what do you do for a bleed risk? And because of the recent advancements, as I mentioned, a lot of folks can do what this case report has presented, and I think folks that are doing this more for trauma simply basically do either low heparin or no heparin until the bleed risk is acceptable. And this is just one example of some folks that treated for bad ARDS, had a head bleed, ran for several days without heparinization, and the patient did fine. One other quick thought in that this is a nice example of some folks from Europe that use ECMO for acute hemorrhagic shock. So not respiratory failure. Somebody comes in bleeding shock. As part of their resuscitation, they put them on ECMO. They reported 10 patients. They had a 60% survival rate. They underwent many operations. They were all unstable. It's kind of an interesting thought for ECMO in the trauma setting, not just for respiratory failure. I think this kind of lends itself to Dr. Alam's talk and some of the other things that could potentially be done in the acute setting, but this was really the only report of ECMO in this situation. Is it the case that all who drink of this remedy recover in a short time, except for those whom it doesn't help, who all die? A lot of this is kind of food for thought. There's much more work that needs to be done in this area to see how we can really utilize this therapy in the setting of trauma. So thank you so much. True privilege to be here with you all, and I think we'll probably do questions when we're wrapped up in a second.